Kiran, I'll log in again and then share screen. Kiran, is the screen visible?
Yes.
Okay. Kumar sir, can we start?
Yes. Am I audible?
Yes, sir, you're audible.
Yeah.
Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is case-based approach to HIV-TB in adults and adolescents, and the speaker is Dr. S. Kumar. Dr. S. Kumar has completed Diploma in TB and Respiratory Disease and MD in General Medicine from MMC. He was associated with GHTM Chennai as RMO and Nodal Officer at the Nodal DRTB Center. He is recognized as Master Trainer for NACO and TANSACS, as well as PMDT services. He is co-author to many papers on HIV and TB, and his field of interest includes care and support for HIV and TB patients. We welcome you, sir, for today's session and request you to start the session.
Good afternoon. Thank you, iTech team, for giving me this excellent opportunity to be in touch with all our colleagues out there. And first of all, extend my warm good afternoon greetings to everyone and happy new year and healthy new year. And now today our topic is case-based approach to HIV and TB. The case will be particularly a IPT, INH prophylaxis therapy case from our GHTM. So our next slide, please. My video is not working in my laptop, so only I will be audible. Anyhow, in the end, I will try to come through video mode. So today our session is a 1-hour session. Our objectives are the HIV-TB co-infection introduction, a bit of historical background and information, then the general principles for management of HIV-TB co-infected patients, and also the management of active TB in PLHIV. So then the important thing, the adverse drug and drug-to-drug interactions of anti-TB drugs when prescribed with for HIV patients, and also the ART regimens in PLHIV with TB co-infection, particularly drug-resistant TB. So the next slide. So, so the HIV and TB is a very fatal very fatal co-infections. The commonest opportunistic infection in HIV is tuberculosis. And tuberculosis is caused by Mycobacterium tuberculosis. That's more than 100 years old. Way back in 1872, Robert Koch announced to the world that TB is caused by Mycobacterium tuberculosis. And we have traveled a long way, and still we are not able to contain or rather eradicate the TB infection. Now we have stepped ahead in telling that we want to eliminate TB by 2035, and our aim is by 2025 or 2030. So TB elimination program has come into place. And also the HIV is rather 40 years old, the viral infection. Way back in 1981-82, it was found out in the USA. Then our first case was reported in 1986, and we have traveled a long way. The National AIDS Control Program, the NACO. So whatever happened, there's phase 1, phase 2, phase 3, phase 4. Now in the first, the Zidovudine monotherapy started in 87, then 95, 94, the triple drug regimen, without the FDA, a cheap regimen came into vogue in developing countries. Then in 2004, in India, we started the ART program, and we have done an excellent job. Now we know the incidence has fallen down. Now it is around 0.22. Previously, during the peak of the epidemic, it was in some states, it was more than 1. Some states it was around 1. Now it is 0.22 according to 2020 reports. So with this background, and the TB infection, the standard 4 drugs, INH, rifampicin, ethambutol, pyrazinamide, are there for more than 8 years. Way back in 40s, first the INH and SM and PAs were found out, then 60s, 70s, the ethambutol, and the 70s, pyrazinamide, rifampicin. Then, so what had happened? All along, no new drug has come for drug-sensitive TB, and we have to use it judiciously to strike at the first time and make the patient get cured of the infection. So if you are not able to follow the proper guidelines, there will be incidents of drug resistance. Nightmare can come. So it's our duty to follow the guidelines, and the fixed drug combination, the 4 drugs are to be used in the intensive phase and followed by continuation phase. So that is an important thing. So the TB also, for more than 100 years, still we are combating the infection. And HIV, we know, now we have the excellent drug regimens. Now we have come with the dolutegravir-based regimen, which is good, very tolerated by the patients, and with good compliance. So the adherence is improving. So that also is there. So about the global epidemiology, that 10.6 million people fell ill with the TB in 2021. So among all TB cases, it was around 6.7% were among the people living with HIV. So in a TB clinic, you go and randomly you are going to check for we are now checking for the ELISA status for all the people. Around 6 to 7% of them will be found to be ELISA positive. So that is the thing, the TB cases, 7% among TB will be living with HIV. So there were estimated 1.4 million deaths among HIV negative people during this time, but there are 187 persons of HIV, people living with HIV, died during the period. Next slide. So what is that? It's a dual impact. It's a dual impact. Both HIV and TB form a vicious circle in the pathogenesis. So what is happening here? In this slide you can see the TB accelerates the HIV disease progression. How it accelerates its what will happen in higher immune activation increases HIV replication and AIDS defiling illness. Same way, the acquired immune deficiency paves way for clinical TB, mycobacteremia, and the TB dissemination. So what is happening in the slide, you can see the worsening immunosuppression in PLHIV. So there will be decreased interferon gamma and Th1 lymphocytes response. So what is that? The cell-mediated immunity is important in TB immunity. So what's happening in HIV? The TB immunity goes down. So what is happening? The alveolar macrophages are weakened. So whenever a droplet infection or a nuclei which stays in the atmosphere goes into the tract, easily they can get TB infection. So that is Mycobacterium tuberculosis, clinical disease occurs. Even a latent TB patient, latent TB is one where the person is exposed to the TB bacilli, but the bacilli they are not multiplying, but they are multiplying very slowly, lying dormant in the patient. And so there is no clinical disease as such, and there is no infective to others. So that is latent TB. That's a very important terminology nowadays we are using. So what happens here in this HIV scenario, the latent TB patient breaks down and there is endogenous reactivation. So he gets a clinical disease. And also when immunity goes down, when they are exposed to the TB bacilli in the community, there will be reinfections or new infections occurring, exogenous new infections occurring in the HIV individuals. So TB, number of TB cases will be more in a HIV setting, more number of patients are affected, and atypical presentation, advanced immunosuppression, there will be lymphadenopathy, extrapulmonary TB. The lesser the CD4, there will be more extensive mycobacteremia. So what happens when there is a TB? The macrophage cytokine production, that is interleukin 1 and tumor necrosis factor, are increased, and also the co-receptors like CCR5 and CCXR4 are activated by the TB infection. So the increased viral entry and viral replication occurs in a TB patient with HIV. So what happens? They progressive faster to full-blown AIDS and succumb. So it is a vicious circle which can be prevented or cut short by our active intervention in both the diseases. So that is a very important slide, in that vice versa, both are causing havoc, and we have to arrest that vicious circle. So next slide. Yeah. So what are the HIV patients at risk of developing TB? This is a bit older slide, but anyhow, this is a very important slide. We have been discussing this slide for many years. So I thought for the nostalgia, we have kept the slide. So what is that? You can see on the left side, HIV negative patient with the purified protein derivative as a MAN2 positive means the lifetime risk of getting the TB or the latent TB become TB is 10% life risk. Whereas in a HIV positive person with the PPD is positive, there is a 60% chance, lifetime chance of getting a TB infection. Here we have to keep it in mind also the diabetes, which is coming up in our country, where it's been called the diabetes capital of the world. So diabetes also, there is a lifetime risk of 30% more of person getting a TB. So like HIV, diabetes also immunocompromised state. So that also you have to keep in mind during this situation. And also what is happening? There is 18 times more likely to get HIV patients to develop active TB than a normal population. So 18 times more active. So this is an important thing we have to keep in mind. So developing active TB once infected with tuberculosis, relapsing TB after stopping. So once even we have done a slide, we have done a study long time back where the importance of ART was shown. Some patients after the ATT is completed, again and again they were getting a reinfection. That was proved by the NIRT study, where the fingerprinting technology they used and found out that even the patient got cured because of no ART before the ART era. The patient again got infection, reinfections, and relapses were common. There is no ART. So becoming reinfected with the second strain of TB that was proved by the study long time back during 2004. So there is an increased mortality also. If you see both HIV and TB together, the mortality is many times increased when there is a deadly combination. So that was why in 1993 or 94, WHO had declared a global emergency on HIV-TB. That was during that time when ART was not available. Both the infections together caused a lot of mortality. So that was the time in the 90s. And the estimated burden of HIV among TB patients in India is around 5 to 6%. That figure was found out in many of the studies done during the period 90s and 2000, early 2000s. Next slide. So what is happening? The manifestations of TB in relation to HIV immunosuppression. So this was a slide usually been there for a long time. Nowadays you can see, because of the advent of ART, we have been giving ART to the scaling up of the ART program. So we catch the, and also we are not getting the patients in the late presentation. So we get them early. So there is some degree of presentation varying during these times after the ART era, and with the active lab support of the this gene expert, the molecular based assays, which we bring out, which easily diagnose the patients early. So what is this slide shows? The clinical presentation is varying. The early phase of the disease, when the CD4 is very high, the immunity is immunity is intact. The patients often come with a post-primary adult type of TB, where apical infection and cavity formation, all these are there. When the late phase comes, there is a varied presentation, like there will be more extrapulmonary disease and disseminated disease. So sputum smear in the early case is often positive and the late case is negative. And you know, the conventional sputum is always 50%, around 50% only the sensitivity, whereas the gene expert and other molecular basis is more than 80% sensitivity. So the chest X-ray appearance also, because chest X-ray is a very common tool for us helping in early diagnosis of tuberculosis. There often shows cavities in the early phase, whereas in late phase, nowadays we are seeing less number of late phase cases because of the active surveillance which has been taken in early diagnosis of both TB and HIV. We are now able to catch them early. So the late phase usually very rare cases, you can say, often infiltrates in the mid and lower lung field. Even in diabetes, you see lower lung field TB lesions. Here also in HIV, in late phase, mid and lower lung field. Then lymph nodes like mediastinal lymphadenopathy, superior mediastinal widening in the X-ray, and cavities may be infrequent, but there will be many presentations like both the effusion will be seen as well as a parenchymal lesion as well as a node involvement. All these three together can be seen in a X-ray chest. So these atypical presentations are common in late HIV phase. Next slide. Then comes the diagnostic. Now we are seeing the clinical picture of it, tuberculosis coming. And we have also the 4S symptoms. All these are coming. We are giving importance to them. That is the clinical history and symptoms. Coming to the diagnosis, we have now improved leaps and bounds, wherein with the molecular test. So the conventional Ziehl-Neelsen sputum smear examination, often it is negative in immunosuppressed patients. So X-ray chest, there will be atypical presentation. And FNSC also, because of the less number of paucibacillary lesions, the yield will not be there. But nowadays, these are all the pictures showing the LJ medium, the solid culture, which takes around 6 weeks time, 6 weeks, 42 days turnover time for the organism, the first to grow, another 4 weeks to see this drug sensitivity. So around 90 days it occurs. So in LJ, nowadays we are doing the LPA, line probe assay, and the liquid culture, which are very, very fast in the turnover, quick in the turnover time. Next slide. So coming to the diagnostic part, now we are there. CBNAT, the molecular base is the preferred diagnostic technique, even everywhere, not alone PLHIV, all the TB patients, irrespective. Initially, slowly we were scaling up the CBNAT. Initially, we had some 50 to 100 machines. Now, more than 600 CBNAT machines are there all over the country. It is an excellent example of how we are slow and steady upscaling of the program, meticulously done by our NTP and NACO and other organizations with quick linkages. We are now able to see that everywhere we can easily take up the specimen on the molecular base. So in the CBNAT is the it's a computer-based CB cartridge-based nucleic acid amplification test. Easily you can put in the cartridge into the slot, and within 2 hours you can get the results. So it is a very easily done. Lot of technical expertise is not needed, and a minimal space is needed, and it can be done. The specimen can be transported, and it can be done usually in all the. I'll tell you what are the specimens we can do. So in a sputum, routinely we are doing. So the conventional, it is far ahead of the conventional sputum examination, the CBNAT or TrueNAT. So it low sensitive sputum smear microscopy is which is there already. I've told you. So cultures are available only in selected labs. It needs high expertise and it takes a long turnover time. So they are available only after weeks or months, and the clinician is not able to act on it. So he gets it late. Whereas in a CBNAT is a preferred diagnostic technique where within 2 hours you can find out the MTB also, and also the RIF resistance through the probes, where it can find out the genetic material. The gene probes are detecting the gene rifampicin resistance in a given specimen. So that is a very important thing which has come. So we are making use of it. So MTB, first step will come as MTB detected or not detected. The second step will be RIF resistance detected or not detected. So within 2 hours, we can find out the drug resistance pattern of the individual. So along with that, next slide. So before going to the clinical presentation, the cartridge-based nucleic acid test. What are the specimens very useful for us? We can use it in the sputum. We can use it in the lymph node, crushed lymph node and lymph node aspirate, cold abscess, pus. Then the pleural fluid, the yield will be little low. Then the ascitic fluid, then the CSF, all these can be done. And also any specimen got from a bronchoscopy, alveolar lavage, any laparoscopy, any specimen we have to do. So as a part of the program, we have to instruct you should have an interaction with the surgical colleagues. So usually in the busy surgical practice, they will pick out the specimen and put it in the formalin. So we cannot make use of our liquid culture and gene expo. You have to instruct or you have to interact with your surgery colleagues and tell them that one portion in normal saline for gene expert, and you can make use of it for liquid culture also. And the other specimens can be sent for formalin based for HPE. So this is very important thing. If you're not going to follow or interact with your colleagues, then precious specimens you may not be able to get back in a surgical based intervention. So it is very important that you should interact with your surgical colleagues for normal saline based specimen for our gene expert and liquid culture before putting it in the formalin. So what is that here in HIV-TB co-infection? The important thing is that immune reconstitution inflammatory syndrome. So it's a common thing occurs OA as TB is the most commonly recognized OA we know, manifesting as iris after initiating ART. But what is that? Restoration of TB active reactivity delay type of with rapidly increasing CD4 cell. What happens? There is an iris. It commonly includes fever, lymph node, intrathoracic lymphadenopathy. So the mean onset of symptoms is 2 weeks, but it could be as quick as 5 days. We have seen some occasions patients within a week developing this, and the mean duration of symptoms is 3 weeks. So it's very important that you should have know about the iris, because once starting the ART, suddenly patient develops new symptoms. You may think that it is a drug toxicity induced by HIV drug, or you may think that it's a failure or something like that. So you have to be careful. And very low CD4 counts and high viral load, think of the iris, immune reconstitution syndrome. That is particularly the commonest OA is the tuberculosis favoring iris. And some of the studies have shown that 1/3 of very low CD4, very high viral load patients developed iris, 1/3 in some of the studies. Next slide. So what is that? We have seen the lab diagnosis, and also when we have seen the important component once diagnosing what is the iris. But what is that in a resource restrained setting where you don't have the gadgets like a CT scan or other things. So you have a very crowded OP. You are here, this 4 symptom complex for TB screen among HIV has come into help. And the studies, analysis have shown that the symptoms are very sensitive, almost more than 80%, 85%. You can diagnose tuberculosis with this simple standardized screening tool for TB patients living with TB tuberculosis, screening people living with HIV. So what is it? Adult, the current cough, fever, weight loss, night sweats. So every visit, even the patient coming for ART naive patients coming regularly, patients already had ATT and coming back regularly for the ART, all these patients, these symptoms, adult symptoms are very, very important. Symptom 4S symptom complex. In children, same thing, fever, cough, only thing, weight loss, here failure to thrive, poor weight gain. And the fourth thing is the contact with the TB case. Very, very important. Here it is the retrospectively you are going to see for the contact in the parents or the grandparents of the household contacts in children. So there's a very contact history is very, very important in CLHIV, children living with HIV. So this is a very important tool for us to in a crowded place. Next slide. So what is that important thing? The HIV tuberculosis management. So now we have come to know, but we have discussed the lab diagnosis, symptoms, signs, and coming to HIV-TB management. Here it is a very important thing in that we are starting the ART and finding TB. So the drug-to-drug interactions, we should know the common drug interactions and how to the drug, because of the drug interactions, the bioavailability of the drugs will be coming down. So we have to sometimes substitute some of the drugs that we have to keep in mind in whatever stage of the HIV disease. Then the ADR, adverse drug reactions, very, very important, because the adverse drug reactions not addressed properly, the patient's adherence will be lost and the patient may go for a failure, both in HIV and TB. So here it's important that we are in a ART setup as well as in a TB clinic. The drugs, ADRs are very, very important, and we have to keep in mind the pharmacovigilance. We have to report all the cases to the pharmacovigilance, which is there incorporated into our program, so that during the course of the years, we can know what are the drugs which commonly cause side effects and what are the rare side effects. We can easily do that. So the pharmacovigilance should be kept in mind. Next slide. So what is that very important thing about the ART and ATT regimens? So ART is recommended in all HIV infected TB patients. So once the TB comes, means the patient asymptomatic is stage 1. So TB, pulmonary tuberculosis, we know it is stage 2 and 3. So disseminated TB, we went stage 4. So ART is recommended in all HIV infected TB patients to be started on ART regardless of CD4 count or clinical condition, that being there for a long time, irrespective, find and treat. So we have to treat the HIV patient irrespective of the clinical condition or the opportunistic or the lack of infections. So when the dual therapy is required, so ART is not an emergency, you all know. So ATT is the central priority, and we have to advise the patient on adherence and other issues. Start the ART very early. So that is very, very important. Like as soon as possible, the patient should, when he tolerates the ATT, like as soon as 2 weeks and not later than 2 months. So we have to start them on the ATT, then ART immediately. So concomitant ATT and ART is the overlapping of ADRs, so adverse drug reactions and drug-to-drug interactions, that you have to keep in mind. So the co-triamoxazole prophylaxis to be given all patients of HIV with active TB. So it should be there till the TB treatment is over, and the CD4 count goes above 350 on 2 consecutive occasions. So that is important co-triamoxazole prophylaxis, which is very, very important in preventing a lot of life-threatening OAs like bacterial pneumonia, the PCP pneumonia, all these diarrheal diseases, common respiratory pathogens, and also malaria and toxo. Importantly, toxo also is prevented by a simple co-triamoxazole prophylaxis. Next slide. So what is that? What are the things we have to prevent the TB patients, or prevent the TB? So how to bring down the burden of TB among pre-HIV patients? So that is a very, very important thing we should keep in mind. So how we are going to reduce it? Just remember 3 I's. So first I is the ICF, intensified TB case finding at all places. So why that is important is that the patient can be immediately given the TB treatment, so that the arrest of progression of the HIV is prevented. As already know, the TB can accelerate the HIV progression. So we have to immediately see the patient. Then what are other things? So intense early diagnosis will prevent the person transmitting the infection to others. So the chain is cut. So intensified early case finding is very, very important in prevention of TB as a whole in the program, in the community. So intensive case finding, and we know how to find about in the centers, the 4S we have to know. Then comes the INH prophylaxis, IPT. So this is a TB preventive treatment for all HIV patients. Even this has been extended into the program also for all sputum positive non-HIV patients also. The household are taken an X-ray, they are given a MAN2 or the IGRA, then all given INH prophylaxis. That also has been come into the program as such in the NTEP. So IPT is very, very important. We'll see what are the importance of IPT in the coming slides. And infection control. So the third thing, which is not being given many a time importance, is now being given a most important, like infection control. After the COVID outbreak, all the other MDR outbreaks, we are now coming to infection. So what are the airborne infection control measures for prevention of TB at HIV care setting? Is that we have a managerial measures where the people higher up policy making people are there. They are giving instructions to all the lower down and the hierarchy to bring about all the changes in the setup. So that is the managerial measures. Then we have the admin control, whoever in charge of the ICTC, ART centers, medical colleges, LAC, there what is being done, the admin control, where they are planning the fast tracking, seating arrangements, cross ventilation, all these are done. And coming to the environmental control, where a lot of mechanical devices, gadgets are being installed to prevent the infection and airborne transmission. And finally, the personal protective equipments. After the COVID, most things are being given the importance, like a surgical N90 mask, N95 mask. So we are going to give the patients or the sputum positive, we are giving surgical mask, and the healthcare workers are N95 mask. So why this? See, the big droplet, while the patient coughs, means they are all bigger size. Once they go into the atmosphere only, they become droplet. So once the patient coughing, the all big sputum particles are coming. Their surgical mask will prevent them from disseminating into the atmosphere for becoming a droplet. For us, whereas the droplet is surgical, so we have to wear N95 mask, the healthcare workers, so that the droplet infection are prevented from getting into the healthcare workers. So this is the infection control. So all the three I's are very, very important to reduce the burden of TB among HIV, and also to bring about the less mortality and morbidity in the PLHIV. Next slide. So what is that? The screening of PLHIV for TB disease. So at each visit to the ART center, cough, fever, weight loss, poor weight gaining children, night shift. So all these are every time to be done, and pre-ART registration, ART initiation, monthly visits, and every time unscheduled follow-up. Every time this 4S screening had to be done. It can be done by the care coordinator, staff nurse, SMO, and immediately the patient has to be fast-tracked to the doctor, so that, and the gene expert or the molecular-based TrueNat or the X-ray test assets available are to be done immediately, so that infection control is done. Next slide. So what is that recommended approach to TB? So it's a diagnostic algorithm in a PLHIV TB diagnosis. So whenever there is a 4S positive, we have to undergo a CBNAP. If the appropriate specimen is there, suppose sputum is there, or a lymph node is there, accessible lymph node, or a pleural effusion, or a ascitic fluid, or something like that, it can be specimen is available, may be subjected to CBNAT or TrueNat, immediate. So whatever the thing is, that the first thing is that NAT. So NAT is positive, means RIF sensitive or resistance. So RIF sensitive means it is a state drug sensitive TB. Only thing is that CBNAT will not show you about the INH resistance, because INH is a very important mainstay in the treatment of TB. So INH resistance will show. Then we have to give them a first line LPA. So start ATT at ART center, send a sample for the first line LPA, which will show if there is INH resistance. So suppose INH resistance is there, it has to be referred to the DRTB center for INH mono treatment, 6 to 9 months of their quinolone containing regimen. Instead of the INH, they'll be giving quinolone. That is to be taken care at the DRTB center. That is the part of the DRTB. Sensitive means we can continue at ART center and regularly follow up the patients. As you all know, after 2 months, there is a sputum. Their gene expert is not done as a follow-up. So NAT is not feasible for the follow-up, because dead bacilli also be seen, and we are going to see a regular sputum and clinical evaluation, and X-ray if needed is there. And after that, 6 months. Then 2 years we have to follow. Why? Because 2 years after the ATT completed, there will be the first 2 years are very vulnerable. Lot of patients relapse during that period. So that is why we are following them up at 6 months, 12 months, 18 months. That is the important thing. Next slide. So categorize, how to categorize on the lab report, critical investigation, MOL established diagnosis. So we have two things importantly. Previously we were telling microbiologically or clinically diagnosed TB case, RIF sensitive or RIF resistance. So empirical ATT is nowadays not allowed, and also the clinical TB is a new entity being envisaged in the NTEP. So based on the clinical history, what we are going to do is that microbiological clinically diagnosed TB case, RIF sensitive or not. Already we have seen the last diagnostic, last slide. algorithm. Based on the history of past treatment, very, very important that new cases less than 1 month treatment, previously treated means more than 1 month of treatment. Next slide. So new case and previously treated also, we are going to give only the same regimen. Previously, there was a CAT2 regimen which had injection under 8 months. Here, both are given the same treatment. Why? Because now we have the gene expert or the molecular based regimen. We can know the status of the drug resistance. So we are not giving the additional CAT2. Now we are following the same type of TB case, but only thing in a previously treated patient, we will concentrate on the adherence, other issues, any adverse drug reaction, why they interrupted the treatment like that. We have to be always on the alert. Next slide. So now we know the daily dose schedule as per the weight band, so that to prevent resistance, the right dose, right time, right duration. So these three are important so that we don't, as a physician, we don't give under the therapeutic range or over the therapeutic range, toxic range. So it is ideally everything is calculated according to the weight band. We have now 5 weight bands are there for accurate dosing, fixed drug combination. Next slide. So this is important that to prevent that drug resistance and adherence, and at the ground level, the healthcare worker at the ground level can easily easily dispense the drugs according to the weight band. No need to be very, it is very simple step. You can easily dispense the drug at the ground grassroots level in the remote places. FDC, 4 FDC, first 2 months, 3 FDC in the next 4 months. Then comes the, based on clinical decision of treating patient, the CP can be extended by 12 to 24 weeks, like in a CNS TB, when you think that there is a scope for more improvement or there's residual lesions are there, we can give in a CNS TB, skeletal TB and disseminated TB. Extension beyond 12 weeks should be done only at the experts concerned, like a expert panel. You have to refer them after 9 months, 6 plus 3, 9 months, you have to refer them for further continuation to a expert panel. So what is an important here? We are not extending the IP by another 1 month, because we know you do a gene expert, firstly LPA, we know the status of the individual. So if they are negative, no need to get, but so there is no program, there is no place to extend the IP, only 2 months of IP. By the time you know the LPA result, the gene expert already status, so you can boldly go to the continuation phase. Then further after 9 months, you want to continue the drug like in a bone TB or a CNS TB, or to refer to the specialist. Next slide. What is that? We have the various regimens. So we know as a ART physician, you all be aware of all the regimens here given. So no need to repeat it at here. This is only a refreshing slide for you, where you all know. Only thing is that when there is a TB co-infection, the preferred regimen is that TDF 3TC dolutegravir. Only thing you have to give the dolutegravir extra dose during the night time. Why? Because the rifampicin is a potent inducer of the drug metabolizing enzyme, this cytochrome P450. So rifampicin is a potent inducer. So when it induces that, the dolutegravir bioavailability will go down. So you have to give, previously, nevirapine was when used, we are giving, changing to efavirenz, all these, So the rifampicin is a potent drug metabolizing enzyme inducer. So we have to give the extra dose of dolutegravir at the night time. That all you know. And after the ATT is over, 2 weeks you have to wait. Why? Because the drug metabolizing enzyme, it has to go back to the base level. For that, so you have to give dolutegravir extra dose for 15 days. Then you can stop that extra dose so that the cytochrome P50 enzyme touches the normal. So this is an important catch you should know. After stopping the ATT, 2 weeks you have to give ART. 2 weeks you have to give that extra dolutegravir in the night. Then less than 30 kg abacavir, then high, then creatine values are high, you have to modify your regimen with abacavir, lamivudine and DTG. Same time in the TB also. TB also you can give all the regimen in a creatine clearance. No need to bring down the dose. If you have any doubt, get the nephrologist's opinion. So women, there is nothing you can continue with if they are not wish to take TTG for neural tube defect or something, you can ask them to continue efavirenz. And same thing here. You can continue both ART, ATT. These are the counseling you have to give when there is preference is contraindicated like HIV-2, NNT exposure is there. So we have to give, must be replaced with rifabutin. Rifampicin will interact with the PI-based regimen. So you have to give, you take out the rifampicin, give rifabutin. Next slide. So these are all the regimens in ART or you are all well versed with that. For completion only that slide has been put. So what is the role of ART in HIV-TB? Already you know the pathogenesis, you know how it goes about, how the TB and HIV, though you know how both of them get vicious into a vicious mode. So the ART prevents the reactivation of latent TB. So what happens? The latent TB will not get reactivated because of the restoration of the immunity, the cell-mediated immunity in the HIV patients. So reduces short-term TB-related morbidity. So whenever you are not starting ART, what will happen? The ATT-related morbidity goes up. So there will be more fibrosis, the respiratory sequelae all will occur. So you have to immediately start the ART and reduce the recurrent TB. So already I told you, endogenous relapse, exogenous reinfection are brought down by ART, restoring the immunity. So long-term mortality after episode of TB also brought down. So all these are studies proven that the role of ART. Next slide. So what is that? The newer TB drugs. You have a slide on the newer, the bedaquiline already it's there from 2015, a wonderful drug. So it is the first group, that is the mainstay in the MDR TB treatment. So it is a bedaquiline APC 80%. Then this dilamanid is a new drug, not that potent like bedaquiline, but it also is important. Then the oxytolone, linezolid and clofazimine are not new to TB, but already they are old drugs used in the anaerobic infection, used in Hansen's disease. They are repurposed. Now the WHO term them as revisited or repurposed drugs. So they're all very important components of DRTB treatment. Next slide. So what's happening? What is the DRTB? Suppose the patient is being found out RIF resistance, then it means it's MDR. So there are various definitions are there. Mono drug resistant, MDR multi-drug resistant, INH mono resistant, polydrug resistant, all these all you know. Suffice to say, extensively drug resistant, pre-extensive, all these are there. So what are the regimens? There are a little bit shorter MDR regimen for a pure MDR, RIF resistant. Then INH resistance mono means we have a poly-DRTB regimen is there. Then we have the all oral longer MDR. So these are the commonest regimens are being there. Next slide. So what is it happening? So what is a shorter MDR? This is a slide where this is mainly for the more information for the pulmonologist and TB specialist. For the benefit of the ART medical officers, suffice to say that here a pure MDR without a fluorochromic resistance or injectable resistance and all extrapulmonary TB, very disseminated, extrapulmonary can give, but disseminated cannot be given. So inclusion, all these can be given. So these are all less than 1 month. So all these are, you can straight away start them on a shorter MDR regimen because only 9 to 11 months treatment and good cure rate and adherence is good. And that's why we are providing them a shorter MDR regimen. So what is that here? Important thing is to know that injectables are being phased out. The canamycin, caprimycin are being phased out. All oral regimen with the bedaquiline is being done. It's introduced in a phased manner to our program. So next slide. So suffice to say that shorter MDR is for all pure MDR and other things. So what is the exclusion? Pregnancy, because euthylamide is teratogenic and all these things are not, safety is ruled out. So we are not going to use in the pregnancy. On any shorter, this is 7 drugs are given in shorter MDR. Any one drug is not tolerated, you cannot continue with the shorter MDR. It is all like a one-day cricket where hit out target, all 7 to be used the first 4 to 6 months, followed by 4 drugs in the remaining 5 months. So it is like a quick thing solution. So we cannot, any one drug is lost, we cannot continue the shorter MDR regimen. More than 1 month treatment is there, second line drugs, we cannot give. Only thing, if you can demonstrate the LPA, by LPA you demonstrate that they are sensitive, we can give a shorter MDR regimen. So suppose resistant to anything. So INH mutation, very, very important. When you are going to say INH resistance, iodose you are going to give in a shorter MDR. So we have to find out INH A mutation is there, euthylamide cannot be given. So we cannot give a shorter MDR. CAT-G and INH-A mutation you have to see. Next slide. So these are mainly. So now coming to important slide for a benefit of our colleagues. The group now being, after so much meta-analysis and operational research and feedback, the MDR drugs are classified into group A, B, C. Group A are the top 3 drugs, levo or mox, that is the quinolone, bedaquiline, nilotinib. So if the 3 are the first 3 to be given in a regimen, DRT regimen. Group is, remember 2C, clofazimine, cycloserine. Peroxidone is not available in India. So group C is 2C, group B, sorry, rather. Group C is all other drugs are put in group C. They are all inferior to the top 5 drugs. So here comes the pre-extensively drug resistant. Suppose a patient is resistant to a quinolone, group 1 or injectable, it is called pre-extensively drug resistant, pre-XDR. You should not be given shorter MDR, please remember. Suppose a patient is resistant to quinolone on any other group 1 drug with injectable, becomes XDR-TB. Any group 1 drug like levo, bedo, linezolid or injectable also becomes under these drugs he becomes a MDR plus this means XDR. So you have to be given 20 months of bedaquiline containing all oral regimen. Next slide. This is for completion. So eligibility already I told you. Now what is happening, new thing you have to remember is that bedaquiline is being put in place of the injectable in a shorter MDR. Next slide. So MDR-TB, actually what are the things? MDR-TB previously it was 2 years. Now it's 9 to 11 months or 20 months of all oral. So ART is lifelong. So drug interactions will be there. You are giving cycloserine with efavirenz, there will be psychiatric disturbance. Some of the time cycloserine, some other drug interaction can occur in a rare drug interactions can occur in a patient. Then nosocomial outbreaks, you have to be careful. That's why air infection control we are telling. Then comes the MDR-TB. Disease is accelerated, hence more mortality. We have to be very careful. So we have to be very careful. Then next slide. So HIV infection may lead to malabsorption of anti-TB. That's a very rare thing. So acquired rifampicin resistance can come. So we have to be very careful. Then HIV infection MDR are high acceptability, high mortality, both antiretroviral and so treatment is very important. So you have to start the treatment and very close monitoring is needed. In a HIV with drug resistant TB, very close monitoring is needed. Next slide. So what is up now? So 6 to 10 different drugs he has to take. So you have to counsel them a lot. Always monitor for ADR, then pharmacovigilance. Then we have to be very careful. Here nowadays we are having a good linkage with the RNTCP and NACO and NTP. So what is happening? We have a good linkage, cross referrals. So simultaneously we are treating them and we are getting a good results in the MDR-TB. Next slide. So IPT, very important thing. I think we are running short of time. So IPT is a very important newer concept which has come for not alone HIV, non-HIV patients. All adolescents should be screened for TB on every visit. Those who do not report any of the 4S are unlikely to have an activity. We already told more than 85% sensitive. So all negative clients should be offered IPT. So if you are in doubt, you can take a X-ray, you can take it's not mandatory, you can take a gene expert sputum, like that you can do, and thorough clinical examination, get an expert opinion, then start the IPT. Next slide. So what is happening? INH is the most effective anti-TB drug. I told you already, INH and Rifa are the mainstay. So when they are resistant means MDR-TB. So INH is there from 1940s, one of the oldest drug and time tested and very effective drug. So it protects against the progression of latent TB to active disease. Previously we were telling we have to rule out active TB. We didn't have much tools. We had only a X-ray and a MAN2 and a TB. What is that? A sputum. Now we have a gene expert molecular test. Then we have the liquid culture, all this ultrasound and CT abdomen, all this, so we can rule out active TB. So that's why initially we were resistant to give INH prophylaxis. Now it prevents TB reinfection also post-exposure. So when a patient after finishing ART and ATT together, next day also you can start them on a IPT. That's the teaching now we are following. So it prevents superinfection, reinfection, everything, nosocomial transmission. Next slide. So INH is because of the duration of infection, IPT not initiated ART is limited. So ongoing immunodeficiency. So when both are given together, there is a restoration of TB specific immunity by ART. The benefit of IPT might be prolonged when they are given together quickly. Next slide. So why we should not be contraindications or active TB? Because we are going to waste on drug, like if you're not, will promote a drug resistance. Monotherapies avoid to be avoided. Active hepatitis because INH hepatotoxic. Peripheral neuropathy because INH is common thing is peripheral neuropathy. And cotrimoxazole prophylaxis, poor adherence, you have to go counseling. Then only you have to start. Understanding of IPT by the guardian is important. We have to explain to them MDR-TB contacts, INH prophylaxis should not be given because they are INH resistant. PLHA who are completely drug-resistant TB, not eligible for IPT. So drug-resistant TB patients are not eligible for IPT. Next slide. So what is that we should know? The IPT is 6 months, irrespective of this. This is very good. So along with pyridoxine. So next slide. So immediately you have to start the IPT. See, these are all what is the specific situations. Patients previously treated for TB treatment should receive INS for one episode, 6 months. So IPT with ART, second, same thing, should not be delayed when starting a complete course of IPT. Pregnancy also, INH is very safe. So you can start safe in pregnancy. Very good. Adverse event, complete IPT, they become pregnant while taking IPT. So assure patients IP is safe while breastfeeding. Next slide. So these are the special situations, specific situations. So children born to microbiology confirmed TB cases. So they can be given less than 12 months contact TB. So evaluate according to national gain receive. So these are children, we have to be take the help of the experts. So IPT and MDR-TB should not give. TB during IPT, immediately stop the IPT based on the DST results, appropriate TB treatment to be given. So this is if patient defaulting IPT, there are guidelines how to restart the IPT like that. They default twice or more than 3 months, you have to don't give the IPT again. Next slide. So these are the standard scenarios you are going to follow in your ART clinic. So you have to IPT for less than 1 month in total distress for any reason like tox TB. You have to conduct adherence counseling, special counseling, address their needs and other things. More than 1 month, the patient had discontinued, conduct adherence counseling, ensure that they complete a 6 months course. So do not reinitiate. More a chronic defaulter, do not reinitiate IPT. Next slide. These are the specific scenarios. So now we have come to a case study. So here, this was taken during a last year. So what had happened, we will just go through the case study. I will explain to you. You can just, a patient is a ART naive patient, clinical stage 1. A young male who had come and he didn't have a 4S. So his CD4 was 236. So I think that I go. Can you go to the next slide? You can see the card there. Yeah, this is the card. So we are well aware of the card, all the ARTMOs and the our healthcare workers. So the CD4 was 236 baseline, WHO guided stage 1. So he was started on ART initially. So what had happened? The clinician felt that since the CD4 was less than 250, so they were there, but initially they were expecting INS, but they started the patient on INH prophylaxis. So in this scenario, what has happened after 1.5 months, the patient had developed cough, sputum, other things, and the X-ray has shown lesions, and the MTB was detected in the gene expert. RIF was sensitive. So this is a scenario where after 1.5 months of ART and IPT, patient developing pulmonary tuberculosis. So it could be a immune restoration or a unmasking of TB infection. So what had happened? The patient IPT was stopped and patient was started on the CAT, that is the 4FDC. Previously CAT, 4 drugs and started, patient is doing well. So this is a very important point you should know. So here previously our teaching was that you wait for 3 months. Once the iris, something happens, we can give ATT. So wait for 3 months, then give INH. But the latest guidelines have shown that these technical guidelines have shown that INH prophylaxis to be started immediately if there are no 4S symptoms. Even the patient is asymptomatic, start immediately. And once if the symptoms comes, diagnose TB, you have to step up the dolutegravir dose. So this is a case study. I want thanks the GHTM team, ART team for giving me this case study so that I wanted to share with our participants. So this is in a nutshell, we have covered the HIV-TB co-infection, a part of the historical background, the epidemiology, and how slowly we have upscaled both the programs, both the ART and the ATT, as NTP and NACO ART programs, how slowly we have improved the program and upscaled the program, and how nicely we have built up the capacity also. That's why the new year, first distant learning session, the capacity building is very, very important. It's an ongoing process. Sometimes new colleagues come in, older colleagues are not aware of the newer guidelines. So it is a capacity building process which should go on endlessly so that our program is strengthened. And in the longer run, the patients get benefited. The latest guidelines, what we are following, the patients will get the immense benefit. And also we'll have the satisfaction of bringing down both HIV and TB. So I thank you all for your patient listening, and any chat box things you will please let me know. So if you have I can clear it, I can clear it. Otherwise we can, we will all learn together. Please. Thank you so much for the patient learning, and thanks once again, iTech team, for giving me this excellent opportunity.
Thank you so much, sir. So there's one question in the chat box. I request the participants to keep adding to the chat box, or they can even unmute their mic.
The last slide, thank you slide. Yeah, that's okay. There's no slides left out. Thank you, thank you.
Yes. Can we give?
I see the chat box on.
Yeah.
So 5 more minutes left. I think. Wait.
Yes, I'll just read out the question.
Yeah, please.
Can we give IPT to Gilbert syndrome HIV patient?
1 minute, sorry. Okay. 1 minute, I think. Yeah, I'm audible.
Yes, sir.
Yeah, Gilbert syndrome is congenital hepatic dysregulation, the lack of hormones. That's Gilbert. So INH is, because INH is a hepatotoxic drug. So IPT, we should only get the expert opinion from the medical gastroenterologist. So they see more number of Gilbert and doxorubicin in cases. So we get the expert opinion and start them. Once they are asymptomatic and we are starting the IPT, suppose something happens, so we'll have a problem with us. So better to get the opinion through the gastroenterologist and start the INH programs.
Any other questions? Participants can please unmute their mic.
Hello, I'm Dr. Kumar from JSS Mysore.
Yes, sir.
What are the chances of virus if we simultaneously start ART and IPT together?
Actually, if you the recent guidelines that we have to start them together, so the restoration of the immunity occurs faster. But only thing we have to keep in mind about the unmasking of the TB infection, iris, so that if it occurs immediately, we have to stop the IPT and start the 4-FDC, sir.
Okay, thank you.
So what are the contraindications of bedaquiline? So bedaquiline is being first initially done as in the program as a controlled trial, where we have in 6 centers, 600 patients, we have done a bedaquiline controlled program. What had happened, we have from that lot of things we have come to know, and we have been using the bedaquiline easily, and as even previously 2 weeks you have to stay, and daily we were taking ECG like that. Nowadays we are not doing that. Even some centers are starting them an outpatient and monitoring their ECG after 1 week or 2 weeks like that. So the contraindications are the pregnancy. It is not known the pregnancy, the safety. Further, bedaquiline, sometimes there is a innate resistance to bedaquiline is there. We cannot use the bedaquiline, and as such there are no absolute more contraindications are there. And even with the bedaquiline, the dolutegravir regimens can be even given, and the PA basis also can be given with good under close monitoring. So if there are contraindications of the ECG, based on ECG, the QT is prolonged. Say they are given a cutoff value. Say for example, it's more than 5 milliseconds, something like that. You cannot give. That is the contraindication. Sometimes concomitant use of the moxifloxacin or clofazimine and some of the ART can cause a QT prolongation. That time you have to one-to-one basis, you have to see which drug to substitute, whether you have to stop the bedaquiline or we have to substitute in the ART. Sometimes that happens as a ART drug-to-drug interaction with bedaquiline the QT can be prolonged. That is mainly, I think, with the bedaquiline. I forgot what the drug. We had one case where it was a drug-to-drug interaction. Other than that, nowadays being more frequently used bedaquiline because of our experience in the field, and it is now the most favored drug for the shorter MDR. We are going to stop the injectable slowly. So shorter MDR regimen will be 9 to 11 months with bedaquiline 6 months. Along with that, other remaining 5 months, 4 drugs.
Any more questions? Participants can please unmute their mic.
So for the benefit of our colleagues, only thing that shorter MDR is just 7 drugs given the first 4 to 6 months, 7 drugs. So cyanide, etonamide, pyrazinamide, then the clofazimine, and the injectable or bedaquiline. So these 7 drugs. After that, after the 4 to 6 months, remaining 5 months is fixed CP continuation phase. We are going to remove the etonamide, idocyanate, and the bedaquiline or the injectable. These 3 will remove, and the another 4 drugs will go continue for 5 months. So totally 9 to 11 months. Very, very good cure rates are occurring with less morbidity. So that is the favored regimen for the MDR-TB. Suppose we are contraindicated, means we have to go for a 20 months all oral regimen. The top 3 drugs I told you, group A, bedaquiline, moxifloxacin, and linezolid, and group B, 2 Cs, clofazimine, cyclosporine. These 5 to be constituted a good robust regimen, a 20 months regimen all over.
Excuse me, sir.
Yes.
So in some cases, after 6 months of completion, we have seen that there is the lesions. After we do X-ray, the lesions have reduced, but there are few lesions. So we can.
Then you have a provision to continue the phase by another 3 months, and see for the improvement. So there are another 3 months you can continue the 3 FDC, INH, rifampicin, and ethambutol. Only thing, when you are going to give ethambutol for a longer duration, please have a ophthal checkup. Some people develop retrobulbar or optic neuritis later. So ethambutol being given for a prolonged time, please keep in mind about the optic neuritis.
Yes. Sir, and in case of any drug reaction, we have alternate regimen. No? So can do alternate.
In drug resistant patient?
No, the drug rash, skin rashes. Sir.
Yeah, skin rash. Skin rash is minor, means under monitoring you can continue the same regimen. Commonly in our 4 drugs, culprit is like pyrazinamide, then we have this rifampicin. But if the rash is major, lot of area involved with the instincting into the eyes or mucous membrane or the genital region, it's an impending Stevens-Johnson. So you have to immediately stop and get a dermatology opinion so that we prevent the morbidity. So if a minor rash, you can continue along with the antihistamines under close observation. If it becomes a major rash, kindly stop the drugs and do a LFT, because most of the time the liver enzymes, the HGPT will be eliminated. You have to stop all the drugs and re-challenge one by one with the help of the experts. What are the least rash forming drug? You can start first. You can start. Suppose it is life-threatening major rash, never ever re-challenge, because again, if you re-challenge, be a grave thing. So you have to give loose drugs. That is not the regular FDC. You have to give loose drugs for 1 year.
Yes.
Yes.
So in some cases, when the patient has defaulted for 1 month,
yes,
1 month, 10 days, like that.
Yeah, you can restart the, and you meaning anti-TB or ART?
Active-TB, sir.
Anti-TB, you have to restart the regimen. Meanwhile, you have to do again send the assess for the resistance, like doing a LPA for a patient, because in expert once done, if it's sensitive, means you get back the LP results, what is coming, any both are sensitive, then you can restart them and give the treatment a full course, like that's a TB retreatment.
Yes, sir.
Oh.
So in some cases, I've seen that when patient is taken ATT for 2 months and he has defaulted, but later on it has come as negative. When he has come back for again after 2 months or something.
Yeah, the natural process of healing will be also there with 2 months of ATT, and they may get cured. But in the program, you have to evaluate them fully, and then because of the inadequate ATT, we can restart the anti-TB drugs and complete the regimen.
Okay, thank you, sir.
Yes.
Any more questions from the participants? Please feel free to unmute your mic.
Hello.
Yes,
Sir.
sir.
Yeah.
Newly detected patient HIV first day, then
Yeah.
we start ATT or ERT.
Good idea.
This is ART is not an emergency. Immediately you can start ATT, and within 2 weeks you can start ART.
Okay, sir. Thank you.
Excuse me, sir.
Yeah.
Yes.
Sir, any so management of severe TB, sir, like
Yeah.
extensive regions are there.
Extensively severe TB, if it's drug sensitive, we are going to give only the 4 drugs. Some private practice give quinolones also upfront, but usually we give the 4 drugs in the ideal dosage, and we admit the patient and see for any paradoxical that is worsening or something, and we have to see always for any Addison crisis like cortisol level coming down, the patient may go down, so we have to monitor the patient. So ideal to get them admitted for minimum a period of 2 weeks to 1 month, see that they improve, then after checking up again clinically and as well as radiologically, and then you can discharge. So extensively drug resistant sensitive TB, this is the 4 drugs. Extensively drug resistant TB, we cannot give a short MDR regimen because of the extensive lesions. You have to give only all oral 20 months regimen.
Thank you, sir.
Thank you. Sorry, I could not. Because my video is not working, so I could not.
Sir, I don't think there are any more questions.
Okay.
Thank you so much, sir, for facilitating this session.
Thank you so much for giving
all
me
the
the
participants for
Thank you,
patiently listening.
high-tech team. And
Thank you, sir.
Okay.
So can we conclude the session now?
Yeah, sure.
Thank you. Thank you.